Okay, so we're gonna do this week is just DKA, HHNS, so it's partly review and then emergency, which is mostly just kind of focusing in on ABCs, focusing in on what to do on some trauma situations. And then this also has a few practice questions on eight practice questions. So we can do that. Okay, so as part of the review for diabetes, DKA definition, when the body can't use glucose for energy, it will break down fat. The fats will make a byproduct called ketones, which will then appear in the blood and the urine. So that's one of the key hallmarks of it. So it's the presence of ketones. So that's what the K in DKA is for. So that's the most important thing to remember when it comes to DKA, or one of the. What are some of the risk factors that you guys can remember from this, and then we'll add on to. All right, type 1 diabetes. Anything else? That's a risk factor for, because type 1 diabetics don't instantly get DKA. Anything that would be, do you feel might be common for why someone would get DKA? Stress, that's a good one. Yeah, so let's see triggers such as stress. Any other triggers you guys can think of that would make it difficult to make, like Emma? Sure, that could be one. Alcohol can lower your blood sugar too. That's an interesting thing. Missed out, definitely missed alcohol doses. Missed alcohol. missed missed insulin. Huh? Yeah, I guess that's true. Okay. Oh yeah, because it lowers. Yeah, yeah. So space bars now. There we go. Do I sound robotic? The internet, the internet's not too good right now. Can you hear me okay now? Infection's a big one, yeah. So infection kind of goes with stress. So MI, infection, alcohol. So to explain that one, alcohol lowers your blood sugar, so hypoglycemia, and then your body is trying to get uh, is trying to get more sugar, so then it releases a bunch of sugar, and then you don't have a way to get the blood sugar down or blood sugar back down. So it'd be like hypoglycemia, ketone production. So glycogen, a bunch of glycogen stores get used, blood sugar goes up, and then your body kind of overcompensates, doesn't have the ability to make insulin, so sugar stays up. Yeah, alcohol has that interesting relationship because it can also, if you are taking your insulin, it can also just make you hypoglycemic. like and stay hypoglycemic, like kind of just full on hypoglycemia. But yeah, these are going to be the main things. So someone said not knowing the diagnosis, so that's very common that people will find out they have type 1 diabetes because they come into the ER with DKA. I guess this would be over here. Leading causes for development of DKA. Yeah, well, look, so it would be inadequate treatment slash not knowing you have DKA, not knowing you have in type 1 diabetes. So not getting insulin treatment because you don't even know you have it. You're not adhering to the insulin. Um, and then yeah, new onset diabetes kind of goes with that. It is rare in type 1, type 2. It can happen, but it's more rare. Do you know why it is more rare in type 1 versus type 2?
Because in
Or
type 2,
yeah.
the make produces insulin.
Yeah, so type 2 still makes insulin. So that for that reason, the effect of going into going into making ketones doesn't occur as quickly. Yeah, that is a Kaplan question. I think that comes up a lot. You'll see that multiple times. So we'll go here. So not as much for type 2 because our body's still capable of making insulin. Therefore, it's capable of making use of the sugar that it has in the bloodstream, and therefore doesn't have to go into making ketones through um, gluconeogenesis by breaking down fats. Okay. Corticosteroids will increase your, yes, so corticosteroids will increase your blood sugar. That's going to increase the risk of that as well. So that's something to take into account. So someone with diabetes and maybe asthma or some sort of condition that has steroids will have to be more careful with their uh, management of sugar. So we could try that. Chronic steroids. So what are some of the manifestations of DKA? All right, the three P's. All right, what are the three P's? And what else can we think of? Ketones in urine. Ketones in the blood slash urine. It's gonna be a big one. So polyuria is going to be one. So making a lot of urine. Abdominal pain is something that can happen with this as well. So abdominal pain, polydipsia for another one. And what's the other one? Polyphagia. Okay. So as a reminder of uh, kind of what kind of goes on there. So your blood is gonna be high sugar. Your body is not gonna be able to make insulin in order to use the sugar for energy. So in your body's mind and in your body's system, it thinks it doesn't have enough energy resource. It can't tell the fact that there's not making insulin. It can't tell that and it's in the way the body works, it just thinks that it's just not getting enough energy. So you become hungry because you're trying to get energy according to your body. It thinks it's not getting enough resources, it's not getting enough carbs. So that's why you are hungry. Your body's also gonna be recognizing that you have a lot of glucose in the blood. So it's gonna try to get rid of some of that through the urine. So you're gonna be peeing some of that glucose out. And then because you're going to be peeing so much because your body's trying to get rid of that sugar in the blood, you're also going to be drinking a lot of water. So it all kind of feeds into each other there. So these two feed into each other. You're peeing a lot to try to get rid of sugar. Then you have to drink a lot to try to get dilute the sugar in the blood, and then also because you're peeing so much. And then this one because your body thinks it's not getting enough resources. It doesn't recognize that it's not because it's not getting enough, but because it just can't make use. Ketones are the consequence of making uh, of your body making breaking down the fats into sugar. Alongside the abdominal pain, Celeste mentioned hyperglycemia more than 300, so we can put that here. So glucose over 300 is going to be your most common cutoff that you'll see. The BHB, yeah, the main ketone. This one, honestly, you don't have to know for the test, so that's why I just kind of have it here. But that is a blood lab that you can do. So this one is a blood lab. Usually they will just go off the urine sample. Increased anion gap, that's also true. So I have some of that stuff written down here. For other stuff that is physical manifestations, do you guys remember the fruity breath? The Kussmaul respirations, yes. Alter level of conscious lethargia from all of that having to do with the dehydration, cerebral edema. But yeah, the Kussmaul, it is going to be the consistent, deep, tachypnic breathing. So really fast, it's trying to blow off CO2 to correct acidosis. The fruity breath, it's because you have that's the smell of acetone, which is a ketone. So you're starting to smell that in the breath. There could also be some nausea, vomiting as well. So all of these things are going to be taken into account. So a lot of acidosis, confusion, dehydration, and loss of electrolytes. You're peeing a lot of stuff out. You're potentially vomiting stuff out. You're having shifts in you're having shifts in fluids due to the change in solution solutes in your blood, hence the cerebral edema. So that's kind of what's going on there. You mentioned the glucose above 300 for this one. The ketone blood lab, you don't have to know. You don't have to memorize that at all. But I included it here. More than 3.8 is considered abnormal. The ABGs make sense that we're going to have metabolic acidosis. That was one of, when we were doing the ABG chapter, that was one of the main examples for that. So let's see. So the bicarb here is going to be decreased. You can kind of think of it like being used up to decrease the blood acidity. These are some of the ranges that kind of correlate with it. Not a well, kind of a hard science, but not something for you to hard memorize. Just maybe like a general reminder on how to read the ABGs for that. The big thing that you guys go over for this one is going to be the anion gap. So the purpose of the anion gap is to kind of like mentioned here, to identify the presence of any unmeasured anions. Anions meaning negatively charged things. So this would be acidic things such as lactate, ketones. So if your body has a bunch of ketones as byproducts, the anion gap will be something to identify. So it would be a way for you to be able to tell apart acidosis, kind of like the presence of the presence of acids that are not typically measured in blood labs, for example. So something you are going to have to know how to do is calculate it. So what is the formula for it? So yeah, the anion gap is going to be the sodium minus the chloride plus the bicarbonate. There is also a number that includes the K, but usually it doesn't. Usually the value will be calculated without the potassium. So when it's not including the potassium, which it usually doesn't for the formula, the normal gap is going to be between 8 to 12. DKA would be a number higher than 12, as shown by essentially meaning that you have the presence of acids that are not accounted for. What that means is if you take a look at the formula here, your chloride, from when we've been in clinical, we know, or if we've had to do like the write-ups uh, on the paperwork, like the post-clinical write-ups, and we had to do one on chloride. The main thing that usually comes up when we do research on it is that it manages your acid base. Uh, so the chloride is kind of one of your compensating factors, while your bicarbonate is a buffer that tries to kind of hold back the acidity from getting too much. So in the presence of when you have acid-base imbalance, your chloride will increase automatically for kind of compensatory reasons. But the chloride is also a negatively charged thing. So if you have a lot of acid, your chloride doesn't feel the need to compensate because it like there's enough. It's kind of complicated, but it's enough negatively charged things in your blood. Chloride doesn't feel the need to go up. So, but the bicarbonate will still be affected because it's trying to create a buffer against the acid. So for that reason, the anion gap would be the way it is. I know that's pretty confusing. They don't really go into detail for the anion gap in this class, but if you were to watch like a really detailed video, it kind of goes over why it is the way it is. But to make a short story short, it's just that when you have the hidden anions, aka your ketones and your lactates, the chloride will not increase like it normally would because the body feels that there is enough anions, enough negatively charged things that it doesn't make the chloride go up to compensate. So this measurement will have uh, a different number. That's why the number will be higher, just because the numbers work out that way. And the reason that this is effective for determining that is because in the cases where those hidden anions are not there, you will see the chloride number compensate and increase, which would lead to a number that's within the range. So for this class, the main thing you really need to know is if this anion gap number is above, is a higher number, it means that there are ketones or lactic acids in the body. But having an anion gap within normal range does not mean that there is not acidosis occurring. It just means that it is not occurring with what we can measure. So there is such thing as hyperchloremic metabolic acidosis, which is acidosis in the presence of high chloride. So that would be a form of acidosis where there's no lactates or ketones that are keeping the chloride from compensating. So just keep that in mind. So having an anion gap within normal range does not mean you're not in metabolic acidosis, but having an abnormal anion gap means that you have either lactates or ketones in the body, things that we normally cannot measure. Well, you can measure the ketones, I suppose, through the blood lab, but typically things that we don't really measure that much. I guess you can also measure the lactic acid, but it's a way to do it with your normal. It's a way to do it without needing like a CMP or needing to draw that specific lab. So just being able to get it from just the serum sodium, the serum chloride, and the serum bicarbonate. Does that make sense, or do you guys feel like want me to try explaining it a different way? You don't need to know anything too deep into detail, but okay. So let's see how a better way to explain it would be. Let me try writing something down. Okay. So anion gap used to detect ketones or lactic acid using the BMP values. So that would be using your sodium, your chloride, and your bicarbonate blood labs. Slash CO2. So you can see that's in the blood labs, you can see in a BMP a CO2 instead of a bicarb. Those are interchangeable. So it is a way for you to detect ketones or lactic acid using these values without needing to specifically draw a ketone. It's because otherwise, if you're trying to draw this one out, you're going to have to specifically draw this ketone, or you're going to have to specifically draw the lactic acid. So this would be a way for you to detect that there might be something going on before you have to draw the specific lab. So if you were to just do a random BMP on someone, um, and you see that the anion, you can calculate the anion gap using anybody's BMP, and you see that there's something off about it, you can then well, you won't be making the choice, but doctor would then go from there and be like, maybe we need to draw, we need to do further testing, further diagnostics to see what's going on. But it's a way for you to kind of get an idea that there is ketones or lactic acid without needing to draw the lab specifically, without needing to specifically have a lactic acid lab draw. Just using your standard daily blood labs, it would be a way for you to detect that. When anion gap is high, it means that is high equals ketones, lactic acid in blood, leading to metabolic acidosis. But anion gap being within normal limits does not necessarily mean that there is not acidosis happening. Such as with someone with COPD. Example would be COPD having respiratory acidosis. Because in this instance, if you know a respiratory acidosis, you're gonna have your bicarbonate decrease because of the buffer. Normally, your chloride is gonna be your big thing that manages your acid base. Your chloride will increase to make up for the decrease in bicarbonate, typically. So when not in the presence of ketones and lactic acid, your chloride will make up for the loss in bicarbonate. When having general acidosis, bicarb decreases to act as a buffer, but then the chloride will increase to make up for the decrease in bicarbonate. Which then, if you look back at your formula, if this number were to go down and this number were to go up, it would, because you're adding them together, it would kind of make up for the difference, leading to a normal anion gap. Because it's making up for this one going up would be making up for this one going down. So it would end up being like a net neutral, and then keeping the anion gap um, within this value, despite there being acidosis. But when you have the ketones and the lactic acid in the blood, that one is going to be a lot more impactful and leads to the loss of bicarbonate. So this goes down, but the chloride does not increase. And therefore, this number would go higher, or the anion gap would go higher because this value is going down and this value is not increasing. So this amount that you're subtracting from your sodium is less than it would be otherwise, meaning this number would be higher. Okay? Okay. So honestly, the main thing for this class you really need to know about the anion gap is how to calculate it. So I do want you to know this calculation. I want you to know what the normal range is. And I just want you to really know that it being high means DKA. And just know that it being normal does not necessarily mean that there is not acidosis happening, as in this example here. But that's the main three things that you need to know from this. There's a lot more that goes into the anion gap, but you don't really need to know it um, for this class, and you probably won't need to know it unless you're doing something. Maybe probably in the ER where you would be seeing a lot of people coming in for DKA, and you need to stabilize them. You need to get those initial levels going. Um, but a phrase you could hear would be closing the anion gap, which is an attempt to get this number back from above 12 to back to normal range. And the gap closing is going to be based on the bicarbonate going back to normal numbers. But to do that, you do that by fixing the underlying issues. It is not recommended anymore to provide bicarbonate unless it's like very severe. Providing bicarbonate from the evidence-based practice has been shown to not be that effective for overall outcome. So the focus is going to be on fixing the underlying issue, which for DKA is going to be what? Giving insulin. That is going to be your main thing. Okay. Any questions so far? Because I know that was probably kind of confusing on the anion gap. And not much detail was provided. To be fair, they don't test too much on the detail, but it hopefully that helps to kind of get a general idea. Okay. So next thing, the creatinine and BUN. So one of the big things with DKA, like we mentioned, is you're going to be peeing a lot. You might be vomiting a lot. So you're going to be losing some fluids. You're going to be dehydrated. That's going to be a key thing about this. You're dehydrated. So with the dehydration, you can see an increase in your BUN and creatinine, or you will see it with severe dehydration. So your kidneys are not going to be enjoying the severe dehydration. What about your potassium? What about your electrolytes? We talked about how you're losing fluids, you're vomiting, so that's going to affect your electrolytes. So in what way does that affect your potassium and sodium? Okay, yeah. So in the beginning, the potassium, yeah. So potassium, you will find it will either be within normal and then lead to becoming low because you're gonna be peeing a lot of that stuff out. Initially, it's kind of an interesting thing. Initially, it actually will be maybe slightly elevated, go back to normal, and then eventually become low. So one of the so potassium will be kind of going in a range of high, normal to low. But usually by the time that this person gets stabilized, it will end up being low, normal like low, rather than so it's kind of like when someone has an asthma attack, the ABGs when they're having their asthma attack, the initial asthma attack, they will be alkalotic because of their compensation, but then they become acidotic afterwards. And realistically, you won't see them at the stage where they're alkalotic, but it's technically what would happen. So it's kind of the same here. You will typically see them when the potassium is low, but technically it does go high initially because the acidosis initially will push the potassium out of the cells, which will lead to an elevated potassium for that small time period. And then your body will have the osmotic diuresis, so you will be losing a lot of fluids because you are going to be having a lot of glucose and that you're trying to get out, and then you have this potassium that's increased as well in your blood now because of the acidosis pushing the potassium out. So you're peeing it out. So now your potassium will become normal to low uh, because you're getting rid of it. And that's usually the state you're going to find it is going to be either low or like close to, or it's more likely going to be on the lower end than it is going to be on normal end, but it does technically start higher initially, but you're going to find it low. And that's the main thing you should really focus on. What is another thing that might cause potassium to be low? Vomiting? Yeah. So other factors is the fact that they're vomiting. What about anything else? Polyuria? Sure. So that kind of goes with the diuresis part. 'Cause you're going to be peeing. What is something else in the overall treatment plan that has an effect on the potassium? Yeah, the insulin. So insulin therapy is going to have an effect on potassium because insulin helps to drive glucose and then also potassium into the cells. So, which means it's going to make your potassium lower. So that's going to be one of the things that you're going to have to be mindful of when you're providing insulin therapy for this person, because you do not want to drive their potassium too low because we know that potassium is very sensitive for the heart. And a potassium um lower than 3.5 is abnormal, but lower than 3 is going to be when you're going to first start seeing some changes in your EKG. So that is when it starts to become bad. And in terms of your insulin therapy, there's a number that you have to be making sure that your potassium is higher than before you want to be doing the 3.3, yeah, before you're going to want to start the potassium replacement or insulin replacement. Because otherwise you could then drive them into hypokalemia and then they could have a heart thing go on that wouldn't be helpful. So then your sodium, you're peeing, so you're gonna have some hyponatremia. You're losing it in the urine, and then you can also actually have dilutional hyponatremia because you have so much glucose in your blood. You're pushing more water into your bloodstream, so then there's too much water, sodium stayed the same. So you can have delusional hyponatremia and then you're peeing stuff out, so then you just have depletional hyponatremia. So just you can have low, the end all be all, you can have low sodium, which we know can have some of, if we go back up, the abdominal pain can be caused by the changes in electrolytes. If you recall, the potassium and sodium being abnormal can have an impact on your gut, how fast it's moving. So that can slow it down, that can give you the abdominal pain. Remember, hyponatremia and hypokalemia can both lead to certain deficits. So potassium, heart stuff, sodium, it would have to be really low for you to have some of the neurological deficits, but it can also cause muscle weakness, muscle twitching, difficulty breathing, etc. So that's something to keep in mind. For your serum ketones, you don't have to memorize any of them. So yeah, honestly, don't worry about it, but I did include it here, but you don't have to worry about knowing the numbers. It's just kind of for reference. Some of the things that you will need to know would be patient teaching. So they're really big on patient teaching for this because you guys have gone over diabetes so many times. So they really want you to really know this because it's very common. So what are some things you would tell a patient for when they should be testing their urine ketones? Like getting that tested, etc. Definitely when they're sick. When their glucose is above 300 would be like DKA, but I've seen recommendations when it's above 250. So before you get fully there to test it, so maybe have like at home ketone kits so you can check. Because technically, if you are already uh, if you're already starting the ketone process, you probably want to go get that checked out. So you can start it a little bit earlier, but so blood glucose about 250 plus, get it checked to kind of rule out the presence of the start of it. Usually you want to get it checked out if it's two consecutive tests. Definitely when they're pregnant, definitely when they're sick. So illness slash infection for sure. And then pregnancy for sure. Another one would be when exercising, because for this one especially, when you're exercising, your body demands energy. So if you're already starting to make ketones, normally when you're exercising, it helps decrease your blood sugar because then your body is going to be burning that sugar. But when your body's already starting to burn fat for energy and making ketones, exercising will instead make that process happen faster. Because at that point, your body's already switched over to using the fat as energy. So when you're exercising, you're just making it make more ketones. So when you're exercising, it's important to check because you don't want to be in the process of making ketones, exercise, and then you drive yourself further into acidosis because of that purpose. For the osmolarity, it's going to be slightly low. So you're going to have slightly low, meaning that you are um, normal to slightly low because you're not as dehydrated as you would be with the other one. Slightly. Oh, because I guess you're getting rid of the solutes. So you're getting rid of a lot of the solutes there because you're peeing so much. But it's also not as extreme as the HHNS that we'll talk about soon. With an EKG, that would be related to the potassium. And then you can get a chest X-ray done to rule out cardiopulmonary reasons for the CUSMA. Like if you're coming in and you're having that shortness of breath, they'll probably do a chest X-ray just to rule stuff out. So what is your priority in this condition? Yeah, so it's gonna be fluids because that's one of your ABCs. So Obviously, the treatment plan is going to include the insulin. It's also going to include the fluids, and technically, the fluids are part of your ABCs, so it's going to be the main priority because they're going to be dehydrated. What else? Yeah, electrolytes, insulin, that's pretty much it. Yeah, sure, like safety and stuff. So we'll kind of we'll include electrolyte first. Let's value replacement. So we're gonna replace potassium like we mentioned before. Uh, IV piggyback, not gonna push it. And we mentioned already that you want to ensure it's above 3.3 for starting the insulin because you don't want to drive that too low. So that's gonna be your big thing here. In terms of the rate, it's gonna be 10 MEQs per hour with a peripheral IV and 20 with a central line. So this is gonna be your big thing here. Is gonna be this part right here. Boom. And insulin is only done when the above parameter is met. So with the 3.3 of the potassium, because you don't want to drive it low. And then your rate that you're going to be doing it at 0.1 units per kilogram per hour. Do know that. And it's going to be, remember when it's IV insulin, it's got to be regular insulin only. So he might try to trick you there. Don't get tricked. It's only IV and only IV regular insulin. So then there's a few parameters to keep in mind for when their insulin drip is going. Does anyone remember? You mean like a one-to-one? Like in the like a one-to-one assessment? Is that what you mean? I don't think that's necessary. Oh, huh. Oh, that's what you mean? Oh, like the. Oh, I see what you're saying. I see what you're saying. Okay, sure. I actually didn't know that. Okay, so let's do that. Sure. 1 unit. Is that the idea of it? Actually, Okay. Anything else for this? So there's like a parameter for when you should be kind of starting to decrease the insulin drip rate. So I'll just include this here. When their blood glucose is then below 200, you want to be decreasing the insulin by half. Like whatever the rate is, decrease it by half. Because you also don't want to be decreasing their sugar too fast because it also affects the fluid shifts. Because then part of the thing that's going on is you're driving the fluids like to go where the solute are. If you rapidly decrease it, you're gonna have that fluid rapidly rush back into the cells, which could be bad for cerebral edema purposes. So you want to maintain like a more steady rate of fluid shifts. So initially it's fine when they have so much solute because you're going to um, it takes a little bit for it to even out and then start kind of the scales of the fluid shifts tipping the other way. But once you reach a certain point, you want to be careful with that. So when it's the blood sugar is lower than 200, decreasing the insulin by half. And then you can also incorporate some dextrose IV. So you're giving them a little bit of sugar alongside of this to reduce the fluid shift. So you're not just giving them only insulin, a little bit of sugar so that the fluid shifts are kept under control while their blood sugars are being kept under control. And then there's another warning about trying to see that the rate of their insulin drip is not so fast that you're dropping it more than 100 per hour, because then the fluid shifts to the brain start to happen, and that could lead to confusion, and that could just be bad because you don't want cerebral edema. Any questions on this so far? Okay. HHNS is going to be kind of similar in the sense that you're going to have a lot of the same symptoms, but you're going to have it's going to be a bit it's going to be more it's going to be a bit more severe overall. Okay. For risk factors, it's going to be pretty similar. So you're going to see infection is going to be one of the leading causes. So one of the main things that drives the blood sugar so high is going to still be infection, stress, infection. Type 2 diabetics are more likely to get this, or though, I mean, kind of it's kind of more like the type 1 diabetics won't even get to this point because they would be in severe ketoacidosis by the time their blood sugar gets to the levels that a type 2 diabetic would have this happen. Usually older than 65, higher chance of it occurring, and having other chronic health conditions. but your main thing is gonna be this. What would be the typical blood sugar level for someone to have this happen? Thanks for saying that. We'll include stress and mind. Yeah, like above 600. So as you can see, someone with DKA would already start having symptoms of someone with type 1 diabetes would be in DKA by the way before they get to this number. So they don't even gotta, this isn't really gonna be occurring there. It would just be like severe DKA not compatible with life that someone with type 1 would have, because they're gonna be experiencing things way before they get to this point. Type 2 diabetics still have insulin, so their hardcore complications and hardcore manifestations will not occur until this later point. The osmolarity, because they're going to be so dehydrated. So you can think of it like a lot of the manifestations outside of the acidosis related ones you're going to see. So you're going to see really hardcore dehydration. So this osmolarity is going to be high because they're losing so much fluid. They're losing so much fluid and not in an even amount compared to like DKA where they're losing fluids and electrolytes, but it's more in line with each other. Here it's just pure on, we're losing fluid. And um you have so much solute and you have a lot of solute and a lot of fluid loss, so it ends up with a high osmolarity. As shown here, your ABGs will not be showing any acidosis. The main issue here is going to be just the insane presence of um, sugar in the blood, leading to fluid shifts, leading to the urination, severe dehydration because your body's trying its best to get rid of it, but there's no acidosis occurring. Ketones not present, very little to no. But your main thing is going to be severe dehydration, altered level of consciousness. And very similar to the other manifestations. So the 3P is still present. The diagnostics are going to be very similar to DKA because you're running the same labs. So if you are taking a ketone lab, it's not gonna, it's just to be to rule out, it's not gonna show anything. It's gonna be normal. You're still doing your CBC, BMP, looking for your ketone labs, sorry, not ketone, looking for your kidney labs, getting the urine sample to see the glucose in the urine, the presence of ketones in the urine, which there won't be. You can do an anion gap here with using your BMP, and it will come up normal. So no need to get a ketone lab if you have your BMP getting your anion gap. Management is going to be the exact same. You're going to be getting your IV fluids, your potassium replacement, and then your insulin once the potassium is replaced. There is one special thing that's extra with this one. Because you're so severely dehydrated, you're so severely hemoconcentrated, you have a higher risk for clotting. So you could get heparin because of the hemoconcentration can cause clots. Okay. So complications. What are some complications you guys can think of with the knowledge of this condition? And I'll add on any extras. All right, let's see what you guys wrote. So hypovolemic shock. Yeah, we are very dehydrated, so hypovolemic shock. You're at risk for you're definitely at risk for clotting. So blood clots that could lead to a lot of different things. Stroke, sure. MI, sure. AKI, acute kidney injury. We've mentioned cerebral edema a few times. Rhabdo, which can then lead to the AKI. So rhabdomyolysis. Severe hypoglycemia. Sure, like if you're from too much insulin. Hypokalemia. And then kind of like from treatment. Um, hypoglycemia. Fluid volume overload from too much fluids, too much insulin. Yeah, that's pretty much it. Any questions? You see that this one was a lot shorter because for the most part, it's you can get the same stuff from DKA and then just know that it's higher blood sugar, more common, more possible in type 2 because type 2 has insulin, so they won't really have the severe effects until like a much higher blood sugar level. Okay. Um, and type 1 isn't really likely to get this because by the time they get to get to this level, they would already be severely in like severe DKA. It won't really get to that point. But they would be severely dehydrated. That's going to be the main thing. So presence of ketones, acidosis is like the major thing in DKA. Here it's going to be severe dehydration. Not to say that dehydration is not occurring with DKA, it is, but not to the same level as HHNS. Just because you have so much sugar that's hanging in there that it's gonna occur. You're not gonna have the acidosis. You're not gonna have the ketones, but the treatment's gonna be the same. Alongside, because of you're so dehydrated that you're going to be having the issue with the um you're gonna be having the issue with the clotting because you're so dehydrated. Remember, that's one of the risk factors for DVT, for example, et cetera, et cetera. It would just be for the rhabdo, it would be partly due to the effects of your kidney. It's not able to process things as well as it's capable of doing. But it's also due to the electrolyte imbalances that can cause injury to the muscles. You have less perfusion. You have less. Uh, you're you're not as able to provide because your body's insulin resistant, so it's not able to provide the energy to the cells, and it's in high stress. It's not able to provide energy to the muscle cells, so that means that they don't have energy that leads to muscle injury, essentially. So, it'd be difficulty getting ATP from, I guess, the trigger to insulin resistance alongside kidney impairment. Um, so it'd be like muscle injury, muscle cell. Well, thankfully, the thing about rhabdo is that the main thing to do with it is you give them a lot of fluids, so that kind of works together. Yeah. So the treatment for this would be consistent with what you're already doing, so that's the good thing. Okay, any questions on either of these conditions? This is mostly review, but some specific stuff on the treatment is probably a bit newer. And an anion gap is new for the most part. You might have seen it before on like a. Sometimes it shows up on the lab, even if you could just calculate it. But and then the ER part is honestly pretty. There's not going to be too many questions on anything specific here. The main thing to know about is going to be your uh prioritization. You're going to get prioritization questions with this part. So this is kind of fluffy. It's just, why do people go to the ED? These are some of the reasons people go to the ER. Most common is some sort of pain. The main thing you're gonna focus on is the kind of like the triage categories. So what's more important? The most important thing is gonna be someone who is at a risk of losing their life or at risk of limb loss. So ABCs or limb loss. Um, that's gonna be your prioritization here. Someone who is having ABC's issues or has the risk of losing a limb is going to be your immediate priority. The next step down would be people who are urgent but do not have an immediate threat to life. Non-urgent would be can wait several hours. And then the next category would be the people who are not likely to survive, which in that case they are probably not going to be seen. Because if they're unlikely to survive, like extremely unlikely to survive, then it doesn't make as much sense to spend resources when other people in this category could be treated instead. So your main idea when you're doing the prioritization questions for this would be picking whatever patient is the one that's at risk for ABCs or limb loss that is not also dead, already dead, or pretty much already dead. So some of the Kaplan questions for this part, I think includes kind of like emergency disaster type. So you have like someone who's like literally no pulse, not breathing, like severe injury versus someone that, like for example, um, is having like ABC or limb loss, and the prioritization kind of changes because this person's probably not going to survive versus this person who can. So definitely practice those on Kaplan. You're going to see things like that more than anything. Uh, for for this section here with trauma or abuse cases, you're gonna want to just kind of leave the IV lines. Anything that's in place, just leave it there. It's gonna be used to like for forensics and stuff. Levels of trauma, you don't have to memorize this. But if you hear about level 1 trauma center, that is the highest level of care. They should be able to care for anybody that comes in. Some of the possible causes of injury for someone going to for severe trauma. Not really the priority here for this section. I think the main priority would be the triage category. So just recognizing that this part of the quiz is really going to be focused in on prioritization, who's more important. And that's going to be, again, ABCs or limb loss. Okay. Um, your primary survey is basically making that decision. So it's going to be your ABCs. And then there's also going to be your D and E. So um, the next in line would be disability such as stroke, fractures, or breaks. Alongside like exposure, chemicals, fire, overdose, etc. So this is something that you're basically doing for everyone. You're just kind of checking to see what's the prioritization. The exception to the rule would be if someone is having excessive bleeding. Instead of ABCs, you do CAB. So just you're prioritizing the circulation instead because the excessive bleeding, you're gonna have to focus in on that. Put all the pressure you can. Um, yeah. So and then the secondary survey is just doing like your head to toe assessment, going from there. Diagnostics, maybe NG2, urinary catheter. They need to be intubated. But the main thing really is going to be, this section is really just going to be prioritization questions. Nothing too specific. It's just prioritization. You know, if somebody, um, let's see, if somebody was having a near drowning incident, and they have a pulse, you're actually recommended to do your breaths first before you start chest compressions. Yeah, because they have a pulse. But if they don't have a pulse, you're gonna be doing chest compressions first. Otherwise, it's for yeah. If they don't have a pulse, do compressions. That's always gonna be the thing. If they don't have a pulse, do chest compressions. That's gonna be that's gonna be your main thing to follow. If they came from a near drowning incident, you're gonna do breaths first. Unless they don't have a pulse, in which case chest compressions still come first. So that's one of the that's not that recent of a change actually. It's been a while, but it used to be that they would recommend to do breaths on those type of patients, even if they did not have a pulse first, but now it's still just no pulse equals chest compressions is just like just like the rule. So even if they're near drowning, if they have no pulse, it's chest compressions. Okay, what else? Like I said, nothing too specific. It's really just prioritization questions. Prioritization questions, and then the rest of the focus is on your DKA. I think they have it. I think it's more than just these two things for your test, right? I think there's another like week 6 maybe is also part of it. So again, focus on burns mostly with a little bit of transplant, a little bit of HIV, a little bit of emergency and triage. Mostly going to be burns and diabetes. So mostly burns, mostly diabetes, a few questions on HIV, a few questions on transplant, and a few prioritization questions. That's going to be what your quiz is going to be mostly about. And like I said, this one comes with some practice questions that you guys can do on your own. Everything has the answers with explanations. Any questions before I end the recording?